Okay, we'll get started. Welcome everybody to this presentation by the Diversity, Equity, and Inclusion Committee. This is a presentation on post-traumatic stress disorder, and our speaker for today is Dr. Maggie Guglielmi, PhD. She is a psychologist and director of the PTSD clinic at the Stratton VA Medical Center in Albany, New York. She received her doctoral degree at the University of Buffalo in counseling psychology. She completed her internship at the Albany Psychology Internship Consortium and continued on to a VA postdoctoral residency specializing in the treatment of PTSD. Her clinical practice focuses largely on the treatment of trauma-related disorders and traumatic grief. Currently, she also serves as the Director of Clinical Training of Psychology and the chair of the Suicide Prevention Team at Stratton VA Medical Center. Welcome, Dr. Guglielmi.
Well, thank you so much for having me. I'm very excited to be here and to have a chance to talk to you about PTSD, especially since it is PTSD Awareness Month. And sounds like I'll have about a half an hour to present on PTSD, the treatment and diagnosis. I know it's kind of a mixed audience of some mental health and non-mental health people, so hopefully there'll be something in here to appeal to everyone. And then we'll have a half hour for questions and answers if you have more in-depth questions to hear about. And just one slight correction, I'm the chair of the Suicide Post-Prevention Committee here at the Albany VA, which is another passion of mine, and that's really in supporting people following death by suicide. So if anybody has questions about that, you can always email me about that later. That's something I've been doing for many years here. That's an exciting part of my role as well. So we'll just get right into it. Just kind of, this is what we're going to talk about today, an overview of what is traumatic stress, how common is PTSD, what are some of the symptoms and how do they present, why some people go on to develop PTSD after trauma and some don't, co-occurring problems associated with PTSD, and what some of the treatment options are. And then there's several slides at the end, which I won't go into in depth because of time, but they have lots of resources for healthcare professionals and other non-VA settings, for trauma survivors, for clinicians, for family. Of course, since I've spent most of my career here at the VA, most of my examples of PTSD are with veterans who are experiencing PTSD after combat or military sexual trauma. But I think much of this is applicable to people who have PTSD from all sorts of different traumas. So just kind of defining, because I do think these days people use the word trauma very loosely, but there's a big difference between kind of daily hassles that we all experience, and then major life events, which although they could be happy, like getting married or buying a new home, can also be quite stressful. And then there's traumatic events in which a person feels that their life or the life or integrity of someone else has been threatened, such as war zone exposure, physical or sexual assault, serious accidents, including car accidents. It could be childhood sexual or physical abuse, natural disaster, torture. All those things count as trauma. And they can be directly experienced or they can be learned about, like learning about the violent death of a family member or close friend. And a final type of trauma is experiencing repeated or extreme exposure to aversive details of traumatic events. So it could be, for example, people who have jobs where their job is to collect human remains after combat or a terrorist attack. That also counts. What doesn't count is repeated exposure to watching news or media coverage of traumatic events. In terms of prevalence, Trauma exposure is very common. Most people you meet every day will have experienced some kind of trauma during their lifetime. So some symptoms after a trauma are to be expected. That happens in the normal course of recovery. This graphic shows what can happen, in a normal recovery from trauma. There's elevated symptoms, which decrease within the first month and then can decrease more so over time. In the case of PTSD, those symptoms don't decrease, they stay elevated. And there's research that shows that if there's no reduction in those symptoms after about a year, then it's very unlikely that those symptoms are going to resolve without some kind of formal treatment. So just, pointing out that many people go through trauma. Trauma doesn't always result in PTSD, and it doesn't always require professional treatment. Oftentimes it resolves on its own by the way, a person responds, the supports they have. Like, we'll get into some of the different factors that can tend to create and maintain PTSD. But it's adaptive to have strong reactions after trauma, because if we experience something dangerous, we want our brains to remember that something's dangerous so that we stay away from it. So thousands of years ago, if you were chased by a saber-toothed tiger, you would want to remember it and react quickly the next time you saw it. Once the tiger goes away, the threat has passed, you want, your nervous system and all that immediate fear that goes along with immediate fear response to go away. And what happens with PTSD, what we see is that fear response, that fight, flight, or freeze, doesn't subside and return to baseline levels in the absence of threat. So one way to think about trauma is that the person is, with PTSD, a person is in a more heightened state of stress and fear than they otherwise normally would be. So PTSD, again, most people who encounter trauma have a normal, healthy course of recovery. About 7% of people go on to develop PTSD in their lifetime. And rates are about twice as high for women as they are for men. In terms of the diagnostic criteria for this diagnosis, directly witnessing or experiencing a traumatic event that happened to you or someone else, learning about it, as I mentioned, and that repeated exposure. Without this, people may have some symptoms that are consistent with PTSD, but without that Criterion A event, what we call it, you can't make this diagnosis. And those symptoms have to be present for, about at least 1 month. When we think about PTSD, we think about 4 important symptom clusters: intrusion, avoidance, hyperarousal and reactivity, and negative alterations in thoughts and mood. So we're going to kind of break this down and get into each of these. Intrusion symptoms, and you need one of these to qualify for the diagnosis. Intrusion symptoms, the Hollywood version of intrusion symptoms is flashbacks, right, where people lose their connection to reality because they're so hijacked by the memory that it's almost as if they're reliving it in the moment. They're not present in this moment, they're acting as if they're reliving the traumatic event. True flashbacks are more rare and tend to be pretty brief. What we typically see in terms of intrusion symptoms are nightmares and intrusive, distressing thoughts. So what does intrusive thought means? It means, I'm going about my day, I'm trying to do my work and focus, and all of a sudden, something I hear or smell or see, any of the senses can activate it, reminds me of my trauma. And now I'm having intrusive memories about this bad thing that happened to me or that I witnessed. And so it's disrupting now my day, my thought process, my concentration. And typically when you have those intrusive thoughts, they're also associated with very intense and or prolonged psychological reactions or physiological reactions. So it might be accompanied by, for example, sweating heart racing, shallow breathing, any of the things that you may recognize from there. So you only need one symptom, one of the intrusion symptoms, but they tend to be pretty intense, the intrusion symptoms. So, and I mentioned that it could be any number of cues that could remind you of it. So for example, if your trauma occurred, if you were in a motor vehicle accident, it might be certain things that remind you of that scene that trigger the intrusive thoughts. Avoidance symptoms. I'm going to spend a little time talking about avoidance symptoms because this is really a hallmark of the diagnosis. And it's one of the things that we know avoidance symptoms tend to create and maintain PTSD symptoms. So avoidance symptoms are simply the person avoids thinking about the trauma, feeling feelings related to the trauma, and may avoid any of the things that they feel like might be trauma cues. So for example, if your trauma happened in a combat arena, you may feel very anxious in crowds. If your trauma happened in a motor vehicle accident, you may try to avoid driving. So what happens with avoidance symptoms is that they might provide immediate relief from the distress. So, okay, I want to, driving makes me anxious. I'm going to avoid it so that I don't have to feel that anxious feeling. That immediate relief is very reinforcing. And so people learn that they can avoid that discomfort by avoiding those situations. But what happens is that in the long term, it interferes with our natural ability to process and reprocess traumas, emotions, thoughts, and feelings. So it interrupts that process, and it tends to feed unhelpful beliefs, about yourself, others, the world that happens when you experience trauma. So avoidance can really drive PTSD, and it's one of the things that we tackle in treatment. It's also one of the things that makes treatment a little bit scary. So if somebody, has a very difficult trauma and they've spent a long time avoiding thinking or feeling or talking about it, we're bringing them into, for example, psychotherapy. We're asking them to do the opposite. We're asking them to think about it, to talk about it, to feel about it, to get into the details about it. So that can be really overwhelming to somebody who's new to treatment. And that's one of the things that we have to work with and educate patients about. The other two symptom clusters here, and you need two of each of these in order to meet the criteria for the diagnosis according to the DSM-5. Negative alterations in cognitions and mood. So I'll talk about this first piece, inability to recall important parts of the trauma. Many people who've been through a trauma can describe much of it in very vivid detail. Other people who experience trauma have difficulty, they have blanks, gaps in their memory related to the trauma. We see both in PTSD treatment. They may have diminished interest in activities that they used to enjoy. They often feel detached from other people, struggling with a lot of feelings of numbness, struggling with, not like I love my wife, but I can't, for some reason, I'm not like feeling it, not able to call up those feelings. So an inability to feel some positive emotions. There can be, when the person talks about it, you may hear sort of some distorted blame, blaming themselves for something that clearly there was other factors in it happening rather than just the person. And then exaggerated negative beliefs or expectations about, the world and the future. So some of those negative cognitions might be that the world is completely unsafe, or I can never trust anyone, or I can never trust men, whatever, and of course that varies depending on what the person's trauma was. The other symptom cluster is hyperarousal and reactivity symptoms. So essentially, if you think about this, with people with PTSD have kind of heightened nervous system activity. They are often in a state of, their body is expecting some kind of bad event or that there's some threat around them, even in the absence of threat. So you can imagine when your body's kind of always in overdrive that you have less tolerance for things around you. So that can lead to irritability, outbursts of anger, difficulty concentrating, trouble with sleep. People with PTSD often just feel wound up or in a state of tension. And it can be very hard to relax. Again, that's a key component of treatment, is helping to people to find ways to kind of bring down the reactivity in their nervous system, to start getting used to the feeling of being relaxed, to feel safe when they are in a relaxed state. Hypervigilance is, of course, a big one that we see with veterans. And, what I often say to the veterans that I work with is that many of these things that are symptoms of PTSD are things that are in fact adaptive in a combat arena. So if, hypervigilance, constantly scanning your surroundings for threat or danger, that's going to help to keep you safe in the combat arena. When you come home and you don't have as many threats as you have in the combat arena, it just becomes really disruptive to your life because you feel like you can never relax. You can't go to a restaurant without scanning the place for what all the exits are and who's there and if there's anything kind of suspicious, all stuff that we see. And I think it's important to normalize that for people, that these things were adaptive at one point. They're adaptive in the eye of a threat. But it's when you can't dial that down after the threat has passed is when it really becomes disruptive in your life. Some people start engaging in reckless or self-destructive behavior. They may seek an adrenaline rush that was similar to the adrenaline rush they felt during the trauma. These are all things that we can see with PTSD, and of course, sleep problems and exaggerated startle. So noises, things like that may make you jump when it doesn't make the people around you jump if you have PTSD. So, of course, we're going to talk about all sorts of different types. We've talked about all sorts of different types of trauma. PTSD is a common consequence of war. There's multiple reasons for that. The intensity of the traumas that people experience, the number of traumas that people experience. Typically, if you go to war, you're not just experiencing, car accident might just be one time, one day. Of course, with war, you're there for an extended period of time. You may have multiple traumas during that time. So about 15% of veterans post 9/11 have PTSD. I also think this slide's important because trauma doesn't always lead to PTSD and it doesn't always lead to natural recovery. Sometimes people develop depression, generalized anxiety, or panic in response to trauma. It doesn't always lead to PTSD, but it certainly can. And then I'll also talk about this a little bit later, but often some of these things can co-occur. Okay, so why do some people get PTSD while other people don't? There's several factors that have an impact on this. That's personal factors, the nature of the traumatic event itself, and then the recovery environment that the person has. So I'll get into each of these. Personal factors. This could be maybe the person had a prior trauma and recovered naturally, but later on in their life, they have another trauma, and it's at that point that they develop PTSD. The more traumas that you have, the more likely that you are to develop PTSD. So if you've had multiple traumas over the course of a lifetime, it's pretty difficult to avoid the diagnosis. Prior history of adversity, sorry for the typo, and history of other psychiatric disorders. Of course, if there's some sort of psychiatric illness or fragility prior to experiencing a trauma, it makes it harder to adjust after a trauma. Demographic factors, I mentioned that women are more likely to develop PTSD. So are younger people. So are people of minority race and ethnicity and lower education. There are also some genetic factors. There's no PTSD gene, but there are some genetic factors that can contribute. The nature of the traumatic event. Why is this important? One of the most consistent findings is that the greater the severity of the trauma, the greater the likelihood of developing PTSD. And whether or not the trauma was intentionally caused by another person or whether it was a natural disaster or an accident. That, you know, the deliberate traumas tend to lead more to PTSD, such as assault, sexual assault, combat. And the interpersonal nature of those traumas also, because it's a person trying to do this to you as opposed to it was an accident or a hurricane or something like that. The recovery environment. This piece is important because the entire recovery environment risk factors are things that can be changed, and they're things that you can address once a person enters treatment, or if it's a family or friend after the trauma. But essentially, there are different factors. How good a person's social support network is a huge factor in whether or not they determine PTSD. And it's not always necessarily just whether the person has a solid support network or not. It's also how comfortable that person feels to rely on their support network. Because some people that we see have great support networks, but they don't feel comfortable relying on their support network to help them through with some of the symptoms. So social support following the event is really key. A good example of this is that children who disclose about sexual abuse and are believed and supported are much less likely to develop PTSD than children who report it and it's not believed or it's not responded to appropriately. Another important factor in the recovery environment is how stressful your life is after the trauma, right? If you have a lot of stress and chaos and you know, maybe difficulties with just kind of getting basic needs met or jobs or homelessness, all of that is more, you know, you're more likely to develop PTSD. PTSD often co-occurs with other problems. 80% of people who have a diagnosis of PTSD also have other diagnoses. The main ones being depression, anxiety disorders, and substance use, which we'll get into in a little bit. Being in a chronic state of stress and arousal can lead to other problems. It can create medical illnesses, high blood pressure, gastrointestinal problems. When you're in that state for many years, it does have an impact on your body. So in the medical setting, you know, sometimes people with PTSD undiagnosed show up in medical settings because they're having maybe some unexplained symptoms. Headaches is a big one. And it may be that if you look into the medical diagnoses and you can't find an explanation for some of their symptoms, it may be that it's a physical manifestation of the PTSD. People with PTSD have greater functional impairments across domains, social, vocational, and they often have a reduced quality of life. So if you're, one good example of this is that if you're afraid to do things, if you avoid doing things because it may trigger your trauma, often what happens is that your life kind of gets small, more and more narrow. Okay, I can't go here. I don't go there. No, I don't do crowds. I don't do concerts, all these things. So your quality of life tends to decrease. Isolation tends to increase. People with PTSD are at a higher risk for suicide. So it's important that, any treatment in any healthcare setting is addressing suicide risk. It can cause a lot of difficulty in relationships. When you're going around and your nervous system's on overdrive, you're more irritable, you find it harder to connect with people, that is going to affect your relationship with your loved ones. And especially like when there's not as much understanding about what the diagnosis is and how it presents. People often have difficulties at home or work. They have higher unemployment rates. Often we also see co-occurring problematic alcohol and substance use. Most people are using it as a way to self-medicate or to help them to avoid those feelings like, I don't want to think about this, so I'm going to go have a couple drinks and that's going to take me to a different place. And then that can just, of course, that self-medication can turn into a full-blown disorder on its own or just really problematic coping. Okay, so the good news is that despite what I think people have thought in the past, PTSD is very treatable. It's treatable in the early stages after trauma, and it's also treated, you know, here at the VA, we see people who have been struggling with symptoms of PTSD for 40 years without any formal treatment. They're coming to us for treatment for the very first time. That is also treatable. And it's, you know, it's a different beast. It's a little bit of a different beast than someone who's just had a trauma and is a little bit more raw. You know, after 40 years, it can become a little bit more integrated in their whole lifestyle and their relationships, the way that they approach things, but it is still very treatable. And we have a wide range of treatment options. So this slide shows outcomes for trauma-focused therapy, medication, and no treatment at all. This is using data from lots of different randomized controlled trials that looked at psychotherapy, medication, and no treatment. And so trauma-focused therapy is the #1 first-line treatment for PTSD. Medications can also be helpful. They're not as effective as psychotherapy. And then, of course, if someone has symptoms, as I mentioned earlier, for a long time and don't get treatment, it's unlikely that they will get better without treatment. So here are some of the different, you know, treatment modalities for PTSD. As I mentioned, trauma-focused individual therapy, and I'll break this down a little bit to talk about some of the different approaches that are utilized. Group therapy can be really beneficial to help to normalize the experience, to connect with other people who are experiencing something similar. I can't tell you how many times we've had people come into PTSD groups that have never been in group before, that haven't met anybody else with a diagnosis of PTSD, who have labeled themselves as crazy, and they come into a group. They find so much meaning in connecting with other people who can really understand their struggles, who can understand what they may be going through without them having to go into a lengthy explanation. Trust is often disrupted with trauma, and so groups can help. Both individual therapy and groups can help to build trust back up, trust in other people. Groups are a particularly effective way of doing that. And again, there's sort of a wide variety of different kinds of PTSD groups. Some of them would allow the people in the group to really specifically talk about their trauma, and other groups, you don't talk specifically about your own personal trauma, but you're talking more about kind of adapting and coping, and you leave the trauma processing for individual therapy. So there's different thoughts about that, different approaches. It kind of depends on a lot of different factors. Family-focused interventions are also very important, helping to educate the family about the diagnosis, what can be helpful or unhelpful for them to do as a family member, bringing the family together to talk about it. All of those things, you know, as I mentioned earlier, that social support is so key, that if we can get family and other significant people in their life involved and on board with what's happening, that can be an important key to the recovery process. Medication interventions can help to manage symptoms, right? They're not going to make the disorder go away, but they can help to manage symptoms. And for some people who don't have access to psychotherapy or are not going to engage in psychotherapy, it is a good option, but I always, you know, encourage people to give therapy a try first if they're willing to do that. Because sometimes what can happen is you give them medication that decreases the symptoms enough for them to function better, but we're not really addressing the core root of the trauma and the PTSD, and so they become a bit dependent on the medication. So and it can, I guess, also treating those symptoms can diminish their motivation for psychotherapy, which tends to be not as quick of a fix, right, as some of the medications. So it's important to think about those considerations when recommending treatment to folks. Okay, so what do I mean by trauma-focused therapy? trauma-focused therapy really is, again, we're trying to dismantle the avoidance. So trauma-focused therapy has to have the trauma as a central component. And you systematically approach the traumatic material. There's various ways to do that. And you're asking them to imagine the trauma, think about the trauma. You might also be asking them to do some in vivo exposure, which is so for example, confronting the avoidance in your everyday life. If I avoid going places because of my PTSD therapist may ask me to go to those places that I tend to avoid, utilizing some stress and relaxation skills like breathing and other things that we've previously taught in treatment, going to those places so that they can create new associations with those environments so that they become less feared environments. And the same thing happens with when you're doing trauma-focused individual therapy and you're talking about the trauma in therapy. The first time or a few times that you talk about it, there may be an increase in symptoms, like a lot of reactivity. The goal is that you keep at it, you keep talking about it until some of those symptoms diminish and the person doesn't have the same association with, they can think about the trauma or the event or the day without getting kind of like hijacked into this high reactivity. What are our goals in PTSD treatment? I talked about this a little bit, but we want to help reduce symptoms, of course. We want to help to integrate their thoughts and feelings. They tend to get separated in a person with PTSD, and we're trying to reintegrate them. So if a person comes in, they tell me their trauma story in a very disconnected way. I know that there's a separation there and that we need to work towards integration. I need to see that the person's experiencing some emotion as they talk about the trauma, and then we work towards that. We want to help the person make new meaning of the trauma, create new memories or new understandings. Sometimes people have a very narrow view of what happened, and as an outsider, you can see, oh, but this, and this were also factors. So it's sometimes helping to kind of broaden their perspective on the event, maybe not assign so much blame to themselves. Treatment can also help to foster the interpersonal connections, like I mentioned. And it's really helping the person gain more control and mastery over their reactions. So instead of just reacting and going into that fight, flight, or freeze mode, it's helping a person to be prepared for what events may be challenging, to remind them of their kind of healthy coping strategies that we'd like to use in those events. And then when they start to feel the feelings, instead of just reacting how they may have prior to treatment, they're choosing specific reactions to help get them through it. And doing all of that helps people to see that they have a bit more mastery over the trauma memories than they previously felt. Let's see how we're doing on time. I know I want to leave time for questions and answers, so I'll run through this quickly. There's lots of good evidence for various forms of therapy for PTSD. Some of the big ones are prolonged exposure, cognitive processing therapy, and EMDR. Prolonged exposure is, again, either in a written or oral way, going over the trauma in detail repeatedly until some of your the intensity of your reactions diminish to that. It also involves, of course, all of these involve education about the symptoms of PTSD, skill building, so helping people do breath retraining, learn meditation, mindfulness, all sorts of other kind of relaxation skills. Okay, so that's the gist of prolonged exposure. Cognitive processing therapy is a little bit of a different focus. It's a focus on looking at where a patient may be getting stuck points in their thinking around the trauma. So, self-blame, I'll just keep using that example because it's relevant. You may be stuck thinking this trauma was 100% my fault. Maybe outsiders can see it's not that. So you work with the thoughts until it starts to change some of the feelings. And that can involve a written account of the trauma or not. And we're just kind of working with their thoughts and feelings to get them to a more balanced perspective. EMDR involves, bilateral eye movements using either a hand triggered by a hand or a light box. And that works with images of traumas and related cognitions and bodily sensations. So I won't get into too many details about that, but all of these have good research to support it. Sometimes patients don't fit neatly into, they may not be able to come in and do 16 sections of prolonged exposure. They may need something that's a little bit of a different pace or a little bit more tailored to their individual situation. So integrative psychotherapy with what we call graded trauma processing. So doing a little piece of the trauma and seeing how the patient responds, not only in the room, but in the week in between therapy. And then gradually increasing to kind of the toughest traumas and a bulkier version of the details of the trauma. These are some other forms of trauma-focused psychotherapy that have good research to support them. Trauma-focused psychotherapy works. There's good data to show that it works, and that the gains that people make in therapy are maintained for the most part. We sometimes see a waxing and waning course where symptoms will go into remission, and then there may be other life stressors or events that cause kind of a renewal of symptoms, and that can be often treated with a brief episode of care to bring them back to their former state. Kind of just shows over time the recovery process after trauma-focused therapy. In terms of medications, these are the medications that tend to be first line for PTSD. The evidence is definitely clear that psychotherapy is more effective at this point in time than any medications that we can offer, but for, as I said before, for patients for which whatever reason therapy may not be an option, or they may not be able to engage in that, then medications are certainly a good choice, and they're a good adjunct to treatment too. Like if a person's not sleeping at all, sometimes just helping to get some of the sleep under control can be really important to making strides in psychotherapy. Benzodiazepines previously have been a thing that people prescribed for PTSD. They recommend against using benzodiazepines for PTSD. They just have limited efficacy. They're not a good long-term treatment. There's of course safety and addictive concerns. And I can tell you from a therapist standpoint, when I see someone after they've had a prescription for benzodiazepine and they come to treatment, it's very hard to get them to try to do some of the other skills sometimes, because that, those benzos work so quickly that nothing in therapy kind of works that quickly. And so they just would rather take that than sit down and try and do deep breathing for 10 minutes or progressive muscle relaxation. So just kind of a caution to prescribers that they really recommend against prescribing benzodiazepines. And I'll just say a quick note about marijuana, because I know this is a big thing with medical marijuana. And lots of people with PTSD say that it's helpful. I think it's another one of these things that's helpful in the short term, but in the long term, more of the research on this recently shows that it decreases the pace of recovery. So not that people who are using medical marijuana can't get better in treatment, but it slows down the progress in treatment compared to a group that is not using marijuana. I just want to alert you to this resource, the National Center for PTSD. They have tons of resources. You don't have to be, it's a VA website, but you don't have to be a VA provider to go there and find resources that are helpful. They have resources for family, for clinicians, for healthcare providers, mental health and non-mental health. It's a really neat resource. They have research articles and research article summaries. They have CE and CME credit courses to learn more about PTSD and its treatment. Just kind of scroll through these. There are considerations in healthcare settings in order to provide trauma informed care, such as how your waiting room is set up or how your staff are interacting with your patients. So there's a kind of a neat video on here that talks about that. Again, that's applicable to in the video, it's a VA healthcare setting, but it's applicable to other healthcare settings as well. More toolkits that are available on that website for a variety of different professions, community providers, police officers, clergy, and then provider self-care. So if you're someone who treats trauma in your daily practice, what are the things that you can do for self-care so that you avoid, secondary trauma or burnout? Okay, so I just kind of wanted to run through those. All right, so we have some time for questions. Curious as to if people have any, what you'd like to discuss.
If folks would like to jump in with questions, or if you want to put questions in the chat, we can read the questions. I'd like to also thank members of the Damien Center and New Vision students who were in attendance at this presentation also. And we had two questions in the chat. Midway through, Barbara Spink asked if you could discuss EMDR, and I was wondering if Barbara's on the line, were your questions answered, or would you like to hear more?
Yeah, I heard that it can be dangerous. EMDR can sometimes cause problems for people. And, what kind of trauma does that work on? That it doesn't work on like prolonged early childhood trauma, that it's more for specific incidences like you say, PTSD.
Yeah, it is. You're right. It is a little bit more help. Like, so for people who have kind of a lifelong of trauma, EMDR can be helpful, but it is more helpful if they, they have very specific incidents that stand out. So if you have for example, childhood abuse, if you have very specific incidents from that stand out, EMDR can be a good tool. It's not dangerous, but with any trauma processing, any PTSD specialist has to be careful in their assessment of patient readiness for trauma processing. So if someone is main source of coping is alcohol or drugs, or they are very fragile, high risk for suicide, then our first course of action is not going to be trauma processing. We really need to make sure that we're addressing the other things and that it's safe to proceed with trauma processing. Historically, there's been some criticism that people have been too conservative with that thought and feel like are treating patients as too fragile when actually they're ready and need to engage in trauma processing. So it's a delicate balance. And I always let my patients know that PTSD symptoms often get worse when treatment begins because you're confronting things that you tended to avoid. And so it's important that patients are informed about that, because the problem is that if you don't inform them about that, they're not prepared for that. They may drop out of treatment prematurely. And then in essence, you're sort of re-traumatizing them because now you've opened it back up and they're, have more symptoms and then they leave treatment. So it's really important that informed consent is a part of the process of the treatment.
Thank you.
You're welcome.
And we had a question if people could receive a copy of your slides.
Sure, absolutely.
Okay.
And then in terms of PTSD being contagious, I see that question.
Yeah.
It's not contagious. However, in a family system, if you have a parent who has PTSD, what we sometimes see is that children start to mimic some of those same behaviors, or some of that just can be learned behavior. So it's not contagious, but sometimes you may see it within a family system. Or for example, if the person's very isolated because of their PTSD, they may bring like their significant other into that isolation, and pretty soon nobody's really visiting with friends or family. So it's not contagious, but it can, of course, have an impact on the family system.
I have a question. Given that we've just been through COVID, and I've heard people refer to COVID as a disaster in slow motion. are people experiencing PTSD, maybe not from an acute event, but from the prolonged stresses of COVID?
Well, certainly, we're seeing a lot more mental health symptoms, as I'm sure most people on this call are aware that, we're seeing a lot more mental health symptoms because of COVID. Lots of people entering mental health treatment for the very first time because of all the stress associated with COVID. I'm sure that some people's COVID experiences are also combined with some kind of trauma related to COVID, so the death of a loved one or something like that. So there can be new diagnoses of PTSD related to COVID, but it would have to be a trauma related to COVID, not just the stress of it in and of itself.
Because I know PTSD was a concern for the nurses, doctors, techs, caregivers.
Sure.
In the
Yes.
COVID units.
Yes, definitely. Because at that point, it's probably, reaching the threshold of the trauma definition.
Are there any other questions? If you don't want to jump right in, you can always raise your hand by going to the reaction button.
Or type it in the chat.
Type it in the chat. And Barbara Spink has another question.
What the heck?
Go for it.
Are there any kind of alternative therapies that are helpful with?
Oh yeah, great question. I'm glad you asked that. Absolutely. I'm really glad you asked this question because not every person with PTSD is going to be able to engage in trauma processing. It is just, as I mentioned before, if they have other co-occurring disorders, there are many factors that can contribute to that. And that's not to say people with co-occurring disorders can't. Like I've seen people who have more of like a schizophrenia spectrum diagnosis. You can still do trauma-focused treatment with them. You have to be a little careful about that and adapt it. But there are some people that are never going to be able to do trauma processing. Does that mean that there are no treatments for them? No. We have, I'm a big fan of, complementary medicine, other types of treatment. And one of the things that we're doing that we've done in the past is equine therapy, so therapy with horses. There's lots of different kinds of alternative treatments that people say help to relieve their symptoms. Is it going to resolve and reprocess the trauma? Maybe not, but it can significantly help with symptom reduction and get them to a place where they have a better quality of life.
Okay, thank you.
Can you review the second slide of treatment options? Which slide was that? Hang on, let me look at my slides here.
While you're looking for the slide, I'm entering my email address into the chat. And after the presentation, if perhaps you could send me the slides and I could distribute them to anyone who would like them, just send me an email and I'll send you the slides.
Great, that sounds good. Okay, yeah, the slide that got skipped over because I was worried about time. Yep, I'm happy to go into this. So I'll talk first about written narrative exposure. So this is, often in trauma-focused treatment, we're asking patients to do homework in between sessions. And then we're asking them to monitor their response. So if they're writing a little trauma account at home, we're asking them to monitor what's their bodily sensations, their thoughts, their feelings that occur during that process and afterwards, and they report back on that. That's all part of the treatment. Written narrative exposure is helpful if a person is having trouble doing those in between assignments, or maybe you're concerned about their fragility or their risk for engaging in unhealthy coping, then you can have them write about the trauma right there in the session. They give you specific instructions that allows you to complete the writing. And then at the end of the session, you save time at the end of the session to talk about the experience, what they're feeling, maybe to do some stress reduction things right then and there to help them to reduce their level of reactivity. Narrative exposure therapy, also a great treatment. It's helpful for people who have multiple traumas across the lifespan. And it's really kind of putting together all their traumas, sort of a timeline of all their different traumas, writing it out into a narrative. And again, kind of that, writing things accesses different pathways in the brain than just talking about them. So writing components can be really helpful if a person is kind of stuck. And so they're kind of writing about that, helps them to reprocess, to make meaning, to maybe have new insights into the experiences or their role in the experience. There's similar things in the brief eclectic psychotherapy. All of these treatments vary in duration. What I say to patients when I start with them is that my job is to work myself out of a job. We don't want you to be in treatment forever. You don't have to be in treatment forever. Therapy can, if a person's really willing to work and get down to business in treatment and confront their avoidance, they can make big strides relatively quickly in treatment. Let's see. I guess just other cognitive behavioral therapies for PTSD, it's important that they, cognitive behavioral therapy in and of itself and the way that we might use it for depression or anxiety is not the same as trauma-focused cognitive behavior therapy, in which the traumas have to remain central. And, as a therapist, it's important to keep the patient focused on the trauma. You could take breaks from that, but often, people are so skilled at their avoidance that they can give you some other really juicy piece of information from their life that they want to process. And it's important to attend to that. I'm not saying you should ignore it, but people can be really skilled at avoidance that they can dupe the therapist as well. And so it's a, challenging balance sometimes as a therapist to think about, like, is this, how much time should we spend on this new stressful life event versus how much do we, is it avoidance and we need to kind of get back to the root trauma. Can you talk a little bit about trauma associated with childbirth and the difference between PPD and PTSD in new moms? So in terms of postpartum depression, I think that that's not always, that's often not associated with any trauma during childbirth. But yes, of course, childbirth in and of itself can be traumatic. It can be a risk to, life of the mother or the baby. And it certainly could qualify for a trauma itself and turn into PTSD. Sometimes, this is something that could also co-occur, that, depression often goes along with PTSD. Many of the symptoms between depression and PTSD can overlap. You can see the same thing in postpartum depression and PTSD. So I think some of that is just kind of looking at the trajectory over time. Is the focus of the person's distress the event, the trauma of the childbirth, or are their thoughts and feelings kind of preoccupied with other things that more tend to be associated with depression and postpartum depression? Not sure if that answers the question specifically.
We had a question: is marijuana approved by New York State as a treatment for PTSD?
Yes, I believe so. Yes. We tend to not encourage people to go out and get prescriptions for that. Again, trying therapy first. Oftentimes, many of the people that we see are already taking it before we see them, either, as prescribed by a doctor or not.
Are there videos that you've done that we can watch you doing trauma-informed treatment?
So not of me specifically, but if you go to that National Center for PTSD website, there's tons of videos on there, and there's some samples of that, like what it might look like. And I want to say that as a therapist, it can be very intense work, especially when you're new to it, because the person across from you is in a lot of distress when they're describing the details. They're often, for the therapist, pretty horrific details to hear. I've certainly had trainees that I've worked with come to me after going through a trauma count with a patient and, being very moved and unsettled and upset by it. And so that's, of course, addressing burnout and secondary trauma is really important because it can be very tough work. And I think that's also part of the reason that avoidance can happen even in therapy, is because the therapist may be anxious to move away from that trauma account just as much as the patient is, because there's so much distress that can be present in the room. I've had patients who are trying to get through the trauma account. They've gone to throw up in the garbage and come back to it. It's like so it's always a delicate balance of pacing, pushing the person to confront their avoidance, but not pushing them too far that they're in so much distress. We talk about kind of a theory of optimal activation, which is they're activated in terms of thoughts and feelings in this optimal way, which reintegration occurs, but not so much that they're not able to think straight, or so little that they're not feeling anything. So that's one of the things that helps us to monitor how we're doing in treatment, how the patient's doing.
Okay, and Michelle Harris said, this was really informative. Thank you so much.
Oh, thank you. I'm glad it was helpful.
We're at the end of our time. And I'd like to thank you very much for this presentation.
Well, thanks for having me. If anybody has questions, feel free to reach out my phone or email or on the PowerPoint. And I'd be happy to talk with anyone further, provide some consultation.
Okay, you're able to get my email address?
Yes, I got it. So I will send the email. I'll send the PowerPoint to you right after this.
All right. Well, thanks again, and everybody have a good and a blessed day.